Welcome to the Pod of Inquiry. Ready for some thought-provoking cerebral whipping and the destruction of ridiculous medical dogma? Want to shift those stale, moldy old paradigms? Well then, don that thinking cap of yours. Get down in the cave and join our host, Dr. Stephen Barrett, for this week's episode. Let's start spelunking.
Welcome to the Pod of Inquiry, everyone. My guest today is Dr. Sonny Yamasaki. Sonny is a very good friend of mine and a colleague, and he's really a fascinating individual if you want to talk about neuroscience, especially of the central nervous system. Sonny has done some very integral work in understanding different pain pathways and all of the different ways that we process pain. And he gave a lecture at the Association of Extremity Nerve Surgeons meeting in November of 2024 that I thought was just such an excellent lecture that I wanted him to kind of give the lecture again so many more people could see it, and then we could dissect it a little bit. It is very technical. I encourage you to hang in there, but if you want to understand how pain is managed from a pathway process and why some patients after surgery in one extremity will get better in the other extremity, this is the episode for you. So please enjoy this fascinating conversation that I have with Dr. Sonny Yamasaki. All right, everyone, welcome to the Pod of Inquiry. I'm really excited to have my good friend and colleague, Dr. Sonny Yamasaki, back with me. And I've asked him to come on the show today to basically reprise a lecture that he gave at the Association of Extremity Nerve Surgeons meeting back in November down in Key West. And I thought it was such an excellent presentation of really a great way to understand some very complex neuroscience. And so, Sonny, thanks for coming on. I think this is going to resonate with a lot of people that have seen some very interesting things clinically and might not be able to explain them just quite right. And I'll tell you, this happened to me when I first started doing nerve decompressions, and some of the patients with very severe diabetic peripheral neuropathy pain, after we decompressed one leg, they would come back in and they would say, you know, my leg that I just had surgery on feels really great, but I have much less pain in my other leg, and you didn't operate on that. And how do you explain that? And at first I couldn't. I just said, you know, in the back of my mind, of course, not to the patient, well, they must be psychotic or crazy or something, but I'll take it. If they're better, I'm happy with it. And then I guess it was about 2006, maybe, or maybe 2008, but we had a lecture from Ian Carroll, who is an anesthesiologist out at and pain management specialist out at Stanford. And he gave a great lecture, actually at one of the wine and nerve meetings out in Napa, where he talked about, you know, how the signals would not necessarily stay specifically in the tracks that we thought they should be, and that there would be this crossover. So it was a great segue into understanding that no, we were not crazy. The patients were not crazy. This was a real neurophysiological phenomena that can now be explained. And thanks to your work and what you presented last month at ANS, I just wanted to share this with everybody because I think it gives them a much, if they really digest what you're going to present today, it will give them a very strong appreciation and understanding of some of the neurophysiology that's going on with the work that we're doing in peripheral nerve. That was very long-winded. So welcome to the show.
Hi, Steve. Thanks for inviting me.
Yeah, no, it's always a pleasure. So you got a great presentation. You want to go ahead and click it on and see what we have.
Okay, let's do that. Okay, can you see that?
Not yet.
Oh, okay, let me back up.
Now we're getting there.
Okay, and let me hide the floating panel. Show that again. Okay, so let's see. I'm going to flip it now. Okay, how's that?
Yeah, that's perfect. Excellent.
So This came about, for me at least, maybe 3 years ago at the AENS symposium, where we were expecting this level 1 study by Shai Rosen to come out for years. And some of the preliminary data came out that showed that the unoperated control legs improved just as much as the treated legs, and how disconcerting that was for all of us who were waiting for this level 1 study. So I sort of raised my hand in the middle of the meeting and said, well, I can explain that. And everyone turned around and looked at me and said, I said, yeah, everyone sort of at medical school level understands the pain pathway in the spinal cord as the spinal thalamic tract. Mm-hmm. And it's taught in medical schools that there's one spinal thalamic tract, and it crosses over the midline after the pain signal enters the spinal cord, and it runs up the contralateral spinal cord. And 90% of the fibers do that. Maybe 10% stay on the ipsilateral side, on the same side. But for the most part, it's a unilateral system. And I said, there's also the paleospinothalamic tract and the archispinothalamic tract. And they're bilateral. So this might explain that you could get improvement on both sides. And you're probably thinking, well, how can that be? Because we're talking about pain pathways. But the pain pathway actually has a built-in suppression of pain. So it's a descending inhibitory pain pathway that starts in the cerebral cortex and goes all the way back down to the spinal cord level. So being bilateral, you might be able to get a diminution of pain on both sides. So that's what this lecture is about.
And Sonny, before you get into the actual meat of this lecture, just can you summarize Dr. Rosen's study just a little bit, so they'll have a little bit of a preface before you get into the meat of the subject?
Absolutely. That's my first slide.
Okay.
So this is the level 1 study. It's the diabetic neuropathy nerve decompression trial, or the DNND trial. And I'm not going to go through all the details that I gave at AENS. I'm going to try to make it a little more accessible.
Okay.
So anyway, it was a very rigorous study, both scientifically and clinically. I mean, they really did a great job in designing this study. But I'm just going to get right to the point, and that is, so here are the results. They looked at, in each patient, they treated one leg, and they did not treat, or they did a sham surgery on the other leg, where they actually made an incision, but didn't do the nerve decompression on the sham or control side. So the idea is that the patients, when they woke up, wouldn't know if which leg got the treatment and which didn't, to try to diminish any placebo effect. Mm-hmm. And what they got was, at 12 months, both the treated leg, the nerve decompression treated leg, and the sham surgery treated leg improved equally. There was a diminution of pain on both sides. However, when they looked at these patients again at 56 months, the sham legs sort of plateaued. They didn't continue improving, but the nerve decompression, the ND treated group, continued to improve to almost no pain at all at 56 months. And I'll show that in a graph. Here's the graph that was in the paper. So you can see here we have the months all the way up to 56 months. And for the first year, both the treated leg and the sham surgery leg improved almost equally. And in the paper, they actually say there was equal improvement on both sides. And you see that in a gradual improvement at 12 months. And then at 56 months, the sham treated legs sort of plateaued. They improved a little bit, but the treated legs continue to improve pretty significantly. So see, I'm pointing with the mouse. Can you see the mouse, the cursor?
What we can. Yep.
Okay, great. So the question is, can we explain that? In the paper, they said, well, this is probably a placebo effect. And they were pretty much asked to say that by the editors, and, against their first wish. Anyway, you can explain the placebo effect with what I'm going to give you as well. So let's get on to the explanation. And the explanation is better understood if you understand those three spinothalamic tracts. They're the nerve tracts in the spinal cord that convey pain and temperature. And I'm not going to go through a lot of detail here, but I'll show you where in the spinal cord they live. So here's a cross section of the spinal cord, and for the clinicians out there, you'll recognize the dorsal columns here, but we're not going to talk about the dorsal columns much in this lecture. The spinothalamic tracts, on the other hand, live here. This would be the lateral spinothalamic tract and the anterior spinothalamic tract right here. And within those two segments, there are actually three tracts. The neospinothalamic tract is the same thing as the lateral, and that's out here. So we're going to call this, from this point on, the neospinothalamic tract. It's the most recent, phylogenetically recent tract. The older tracts, the paleospinothalamic and the archispinothalamic tract, is in the anterior segment of the spinothalamic tract. So already it's getting a little complicated, right? So in here, it's a mix of the archi and the paleospinothalamic tracts. You can almost think of them as reptilian, right? They're very old.
All right.
They've been around for a long time. So these two spinothalamic tracts are bilateral. You're going to find them if you hurt your arm, for instance, it's going to go up the neospinothalamic tract. So when let's say you stick yourself with a pin, you can tell that immediately. The pain is very fast. It's localizable. You know exactly where in your body the injury is, and it's discriminative. This is the neospinothalamic tract. The archi and the paleospinothalamic tracts, however, mostly convey a slower, more emotional type of pain. So this is not the type of pain that's localizable. So, for instance, way back in the 90s, I was at a camp. We had a campfire on a beach, and I thought I was picking up a piece of wood, but it was actually red hot, and I couldn't tell. And I burned the tip of my finger. And so, the first pain, the quick pain, made me drop it right away. And I felt that, and I'm thinking to myself, and we've all experienced this. You're saying,
Right.
wow, it hurts now, but it's going to really hurt in a little while. And an hour or so later, it hurt really badly. It became emotional. I got nauseous, sort of seasick, and it get to the point where you would rather be dead. That's this emotional, slow pain. And that's what we're going to be talking about here in the anterior or archi and the paleospinothalamic tracts. It's called second pain, and it's slow, it's non-discriminative. Later that night, I couldn't sleep. It kept me awake all night, and my entire arm was in flames. And if I didn't know that I had picked up that piece of wood, I wouldn't know where the injury was, because the whole arm hurt equally badly. So it's non-localizable pain. Okay, then that's conveyed mostly here, not so much here. Okay. So I found these videos online. They're both beautiful and accurate. So this is the dorsal column system. So I'm going to skip this. We're going to go straight to the spinothalamic tract. Okay. So let's see. Let me back up. Okay. We're not talking much about the dorsal columns. That's light touch, vibration, 2-point discrimination. And what we're talking about today is pain. So here we have the breakdown of the lateral or neo-spinothalamic tract and the archi and the paleo-spinothalamic tracts. Again, here and here. Okay, so this is the neo-spinothalamic tract. And I'm going to skip all this and just show you what the tract looks like. So it's a topographic organized tract, meaning that when you look at the spinothalamic tract here, there's topographic organization here, and it's very, very clear. It's very clean. And so this blue represents input from the leg, and this represents pain input from the arm, right? And they cross the midline right away, and then they head up to the thalamus in the brain, and it's a certain part of the thalamus called the ventroposterolateral nucleus of the thalamus, which then, and it's topographic here as well, and then those neurons project to the primary somatosensory cortex. So this would be the fast pain pathway, all right? We'll get into the circuitry down here in a bit.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. I'm constantly exploring new avenues to enhance well-being and address any health concerns. Today, I'm thrilled to introduce you to an exciting supplement called STEM Regen, which I take daily and genuinely believe could revolutionize your health journey as well. STEM Regen stands out as a game changer in the realm of wellness. Crafted from 5 potent plant extracts, it boasts a remarkable ability to stimulate the release of your body's own stem cells from your red bone marrow. Why is this significant? Well, stem cells are the superheroes of our body's natural repair system. They possess the extraordinary capacity to morph into various cell types, aiding in tissue regeneration and repair. As we age, the quantity of circulating stem cells in our system reduces significantly, impairing our body's ability to heal and rejuvenate itself effectively. STEM Regen steps in to counter this decline by kickstarting the release of stem cells into circulation, thereby bolstering your body's innate repair mechanisms. Once unleashed into your bloodstream, these mobilized stem cells actively seek out areas of damage or injury, initiating the healing process. By incorporating STEM Regen into your daily routine, you're essentially empowering your body to tap into its own regenerative prowess more efficiently. I firmly believe that STEM Regen could be a valuable addition to your wellness regimen, especially if you're seeking to fortify overall health and vitality, accelerate tissue repair, or expedite recovery from injury or illness. This first of its kind stem cell mobilizer is changing the game in regenerative medicine. Don't wait to unleash your body's innate healing capabilities. Visit stemregen.co/Dr. Steven, that's with a PH, and use the code SBPOD to get a 15% discount off your first order of STEM Regen.
Okay. So this is what the circuitry in the spinal cord looks like. So the input is coming in from the arm or the leg or the torso, and this is the afferent or incoming axon, and it's conveying pain and temperature. And as soon as it enters the spinal cord, it creates a connection or a synapse onto a neuron in the dorsal horn. This is the dorsal horn of the spinal cord. And this would be considered the primary neuron, right? The first order neuron. And
Sure.
This would be the second order neuron. And
Right.
then the neurons in the thalamus are the third order neurons, which project the cortex. So I'm going to be talking about first order neurons and second order neurons a lot in the circuitry part. Let's see. So yeah, so the second order neuron is going to cross the midline. This is called the anterior right commissure. It's not important for this. And then it enters in this case, the lateral spinothalamic tract, right? So that's this, and it's contralateral. Most of the fibers are crossing the midline over to the opposite side. So this is the spinal tract that most doctors learn in medical school. For some reason, they don't learn the other two, and that's why it's not well understood by a lot of either clinicians or scientists, for that matter. Okay, so this is a repeat, so I'm going to skip this. Again, the circuitry, and this is the dorsal horn of the spinal cord. This is the anterior horn, or the ventral horn. Here's the first order neuron, and here's the second order neuron. And it's heading up the spinal thalamic tract over here. Okay, just more of a 3D version of the same thing. So I'll play this. This is going to show a pinprick in the foot, and then the pain signal going into the spinal cord way up here and heading up to the brain. So you can see the action potential heading up to the spinal cord, going to the second order neuron, going into the thalamus and into the primary somatosensory cortex. Okay, so this is something that most people don't realize, that this first order neuron, this axon, is very long in the foot, right? It's going from the foot all the way up to L2, or probably it's actually L3 in the vertebral levels. So vertebrae L2 and L3. So, and then this neuron is going from that level, the L2, L3 level, all the way up to the brain. So these are long axons. Okay, so now we go, that's the neo-spinothalamic tract. Now we get to the older ones, the paleo and the archi-spinothalamic tracts. So let's do the same thing. You're going to see in this video, hammer whacking the hand, and you're going to see that they cross over both sides, or they rise on both sides to the spinal cord. Okay, so you have the first order afferent, the first order neuron coming in, and I'll show this circuitry in the next slide. But in general, it's going to synapse on the second order neuron. But in this case, in the paleo-spinothalamic system, it's going to cross over the midline just like the neo-spinothalamic tract did, but also it's going to send up an ipsilateral axon. So it's a bilateral system. And the other thing to take note of in this slide is it's not just going up to the thalamus like the neo-spinothalamic tract does. It's sending collateral branches to the reticular formation here and here, the pons, and the midbrain. And these are all sections of the brainstem that control pain. So it's sending input to these pain centers in the brainstem before heading up to the thalamus. And then in the thalamus, it's not going to the VPL nucleus, the ventral posterolateral nucleus. It's going to the intralaminar thalamus. This is a part of the brain that I studied in graduate school, and it's really a fascinating and little understood system. It's going to project to all the pain centers in the cerebral cortex. All right, we'll get to that later. So this is what the circuitry looks like. For the paleo-spinothalamic tract, as well as the archi system, you have the first order neuron, and then it's synapsing in the dorsal horn. But the second order neuron is deeper. It's in layers 4 through 5, 4, 5, and even maybe 6. Oops, let me back up. And then, as you saw in the previous section, it's a bilateral axon. It's going up both sides of the spinal cord. So let's see, the paleo and the archi systems, their second order neurons are going to be in the deep dorsal horn. The neospinothalamic second order neuron is in the superficial dorsal horn. And it may not be critical for today's lecture, but it's going to come in later when we talk about the diminution of pain. Pretty much the same thing here in more detail. We don't need to go into that. Here you can see they're sending collaterals in the brainstem to all those pain centers, and they're going to play a really huge role in the understanding of how the descending inhibition of pain operates. So let's see. This is just a reminder that this is a bilateral system, right? And now we go to the archy spinal thalamic tract. This is the really ancient version of pain and temperature. So you would think, if you think phylogenetically, it's really important to have pain in your system to warn you against injury or potential injury, right?
Right.
So even technically, even like bacteria have a version of pain that allows them to sort of swim away from a danger zone. Okay, anyway, this is a slightly different circuitry. It's still going to be bilateral, but in the archy spinal thalamic tract, it's going to involve a more ancient proprio-spinal thalamic tract, which you'll see here. It's an let me play the video. Hammer's going to whack the hand. Now these are going much slower. These are C fibers. They're slowly conducting, and this is the proprio-spinal thalamic tract. So it's a multisynaptic tract that runs up pretty much the length of the spinal cord, and then at the top of the spinal cord, it merges with the paleo-spinal thalamic tract. This is in the dorsal funiculus, in the dorsal half. It's not out here where the spinal thalamic tracts are located. It's more medial, right? But it's going to join the spinal thalamic tracts up here. And I'm going to show this in more detail right here. I have to play through this. This is going to be magnified, so we'll see the circuitry better. Okay. So the C fibers, the first order neuron is coming in. It's synapsing on some interneurons. They're going to then talk to the second order neuron here, right?
Right.
And this is the paleo system here. Now the archy system is in green. The archy spinal thalamic tract is going to. This is actually incorrect. It should be down here in the deep dorsal horn, and then it's going to cross, or it's going to ascend on both sides of the spinal cord, but more medial in here in the dorsal funiculus, not out here. And it's going to, again, it's going to be multisynaptic. It's going to rise through much of the length of the spinal cord, and then it's going to join the anterior spinal thalamic tract higher up in the spinal cord. Okay, so this is the same thing again. In more detail, we don't need to go into this much detail. And this is the summary of all three spinal thalamic tracts. So what they did here in blue, this is the neospinal thalamic tract, and you can see it shot up much faster. It's the fast pain. And the archy and the paleo system are much slower. I'm going to do that again so you can see they made great pains to make that evident. See how much faster the neospinal thalamic system rises.
Yep.
That represents the action potentials and the pain signals. Okay. Okay, so those are the tracts. Any questions, Steve?
Yeah, no, I think the point that everybody should take from this is that there are, first of all, multiple tracts that conduct these signals from an afferent standpoint or to the CNS or through the CNS. And then there's a descending pathway that a lot of people don't think about in pain management, that we have this, for lack of a better way to put it, a dampening effect or something to just kind of turn the stereo down. You know, when you walk into the room and the stereo is just blasting so hard, it's maybe a song that you really liked, but you don't like it because it's so intense. And then by just turning the volume down, which is what the descending pathways do, now you like the song again. You can tolerate it because it's not at such an intense volume.
That's a good analogy, and accurate as well. I wanted to point out that you can go to this website down here. I don't know if you can see it. The Neuroscience Online. It's UT Health, University of Texas Health. It's a beautiful website, and they go into the text is very detailed and accurate as well. Okay, so what is the evidence that the ascending pain pathway is bilateral, right? I'm not going to go into great detail here, but there is clinical evidence that when you injure one side of your body, you can experience pain on both sides. Right? Mm-hmm. So that's the opposite of what we're going to talk about with the level 1 study, where there's a diminution of pain on both sides. All right, but this will explain and help you better understand how you can get a diminution of pain on both sides, because some of the pain is actually ascending bilaterally as well.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. The power of ketones, your body's alternative fuel. The folks at Approved Medical Solutions have done it again. That's right, with their new Clean Ketone Supplement. Imagine your body as a hybrid car capable of running on 2 different fuel sources. These molecular powerhouses cross the blood-brain barrier, providing crystal clear mental energy that many describe as enhanced focus and clarity. But ketones aren't just brain fuel. They're efficient energy sources for your heart, muscles, and other vital organs. Think of ketones as premium grade fuel that produces less metabolic waste than glucose processing. Research suggests ketones may offer additional benefits: reduced inflammation, improved metabolic health, and even potential neuroprotective properties. Approved Medical Solutions Clean Ketone Formula contains nature-identical ketones. I've been using them regularly now and notice a minimum of a 10% increase in exercise performance. To get started, go to approvedmedicalsolutions.com and use the code SBarrett to up your mental and physical game now. Right. Okay. So, Sonny, go back to that slide 1 second, because I was thinking about complex regional pain syndrome, or like they used to call it, RSD or causalgia, when you were showing that I believe you referred to it as the archy and the paleo spinal thalamic tracts. Do you think, I mean, I've never seen this, but I'm not a neuroscience wonk or anything, but do you think that there could be some anatomical basis of why some people develop complex regional pain after an injury or surgery versus another? Do you think that maybe their reptilian system is more still upregulated than somebody who doesn't? There seems to be a preponderance of female to male, like 3 to 4 to 1 in this. Do you think, has anybody from a neuroscience standpoint ever thought about maybe that, because we see peripheral nerve aberrations and anatomical, variants quite frequently. Am I just totally, out to lunch on this? Could there be a wiring flaw in some folks that make them more susceptible to chronic pain?
Wow, I never thought about that. I don't know. I haven't seen that in the literature. So it could be. It could be that it's a genetic thing where, mm-hmm. as you're saying, the paleo and the archy systems are more sort of upregulated. I know that there is a temporal component here. So the longer pain is untreated, and when you go into months of untreated pain, and then in some cases years, you will progress to the complex regional pain syndrome and causalgia and all this stuff over here.
Right.
So it's really important. And one of the take-home messages from that whole section of lectures that morning was it's critical to treat the pain as quickly as possible so that it doesn't progress into CRIPS scenario. So I don't know about, you said women are three times more likely to get it than men. Is that what I heard you say?
Yeah, I think that's pretty well. It's 3 to 4 to 1 in the literature as far as the sex differences in the development of complex regional pain syndrome. And if you look at some of the other issues like neurocognitive disease, like Alzheimer's, it's also, I don't know if it's exactly 3 to 4 to 1, but it's higher in females to males. And people have bandied about, talk about maybe it's an estrogenic receptor that's playing a role, or who knows. But I mean, the epidemiological data is pretty consistent.
Okay. No, I didn't know that. That's interesting. Yeah, so that wouldn't explain the temporal component, wouldn't it?
Well, I think that this is such a complex subject that it's not just one pathway playing a role here. It's multiple pathways and multiple factors, going on. But, the more you look at it, the more complex it becomes.
So the reason why these are listed here is these are all human scenarios where if you injure one side of your body, both sides will feel the pain. So there is clinical evidence that there's this bilateral pain, ascending pain pathway.
Right.
This slide is really to show that here's some clinical evidence using functional MRI in patients who are experiencing different types of pain, that different parts of the brain will actually light up. So this is sort of an overview. This is a person that's experiencing pain. And what you see is this is the cingulate gyrus right around the corpus callosum, right? So this is the cingulate gyrus, and typically the anterior cingulate lights up in pain. And then the dorsolateral prefrontal cortex, and in this case, the dorsal medial prefrontal cortex will light up. This is a little bit too far back, but the primary somatosensory cortex right here and here will light up. And then all the parts in the brainstem that are related to pain will also light up. And here they may be responding to pain input, but also being activated to inhibit the pain in the descending inhibitory pathways. This is, again, the anterior cingulate. So the cingulate gyrus curves all the way around the corpus callosum down to here. And we see this area light up in emotional pain, the really horrible type of pain. Okay, and so this is this slide here. And now we're going to look at this slide, zoomed in. So let's see, this is showing a different patient experiencing a different type of pain. Again, the primary somatosensory cortex is lighting up here and here. A little bit of the cingulate, the anterior cingulate is lighting up down here, right? Other parts of the brain that I haven't mentioned yet that are involved, particularly in this second slow emotional pain, is the amygdala, which is not shown here, the insula, which is also not shown here. Let's go to the next one. So this is that second pain type. This is a patient suffering from emotional, motivational, non-discriminative pain, the really nasty kind of pain. And you can see again the cingulate cortex is lighting up a little bit, not much, but a little bit of the anterior cingulate. And again, that would be the emotional component of pain. The dorsal medial prefrontal cortex is lighting up. Here's the insula lighting up here. I don't know if you can see it on this side. On my screen, our pictures are blocking it out, but this would be the insula. It's it's, well, we don't have to get into that, but this would be the cingulate cortex here, the anterior cingulate cortex, right? So these are all parts of the cerebral cortex that light up for the different types of pain. And now this paper was talking about the descending inhibitory component of pain, right? And all the parts that light up there. So again, it starts with and it's not shown here very well, but the dorsal lateral prefrontal cortex out here is going to be sending signals down to the brainstem, to all those parts of the brainstem that I mentioned earlier. And prefrontal cortex is telling some of the lower order cortical areas like the cingulate cortex and the amygdala and the insula. Prefrontal cortex is saying, hey, there's pain coming up here. Something's going on down at the spinal cord. Someone talk to the brainstem nuclei to go and try to inhibit some of that pain in the spinal cord. So that's basically what's happening. The prefrontal cortex is telling the lower cortical areas to talk to the brainstem. The brainstem is going to send signals down to the dorsal horn of the spinal cord to try to diminish some of that pain input. So it's happening at the first synaptic level, which is amazing to think about. Okay. Same thing here. The same paper is showing all the different parts lighting up for different types of pain. And we don't have to go into great detail there, but here, this salience part is where pain becomes prominent, and it could be fast pain. The pain is becoming more unpleasant. Here, we're actually starting to get into that suffering, emotional, motivational pain, and now the stress that follows it, right? So they're all the same parts of the brain that I just mentioned. They're all lighting up. Okay, now we talk about the descending inhibitory part of pain. So let's see. We all know that there's this, we know instinctively that there's this diminution of pain that happens all the time. Like an athlete on a football field might have an injury and not know it. Right. Because they're focused on the job at hand, right? Same thing with soldiers on the battlefield. So this is all where the pain control pathways is kicking in. And when you're really focused on a task, you may not even realize that you have an injury, or it will be highly diminished pain.
Right.
Now, some people will call that the placebo effect, right? But we can explain the placebo effect with this same pathway. So I wanted to go into the gate control theory of pain, which is pretty much universally accepted these days. Back in the 80s and the 90s, when I was in grad school and a professor, wasn't so much accepted, but today it's pretty universally accepted. And there's an interesting story that goes behind this, but I'm going to skip it for today. I don't know, some of the older folks will remember the old current contents that came every week, and everyone read it every week to see what the most interesting papers for that week were. This is before the internet, so that's what we depended on. Okay, I'm going to skip that. I'm going to skip this. Okay, this is the actual figure that was in the Melzack and Wall paper in 1965. They said that there are large diameter axons coming into the spinal cord, which are predominantly going into the dorsal horn, into the dorsal column system. This is light touch, two-point discrimination, vibration, and conscious proprioception, right? That's what these large axons are doing. They're coming into the spinal cord, and this is all in the dorsal horn, right here, or right here. And these would be the first order neurons and the second order neurons here. The T stands for the transmission neuron. The small diameter axons are coming in. These are the pain fibers. It's not light touch, vibration, two-point discrimination. This is pain and temperature. Okay. And these would be the A delta fibers and the C fibers coming in. And they're now going to the spinothalamic second-order neurons here.
Right.
But this SG neuron, this is in the substantia gelatinosa. Both of these are making a synapse, and this is they propose that this interneuron is an inhibitory interneuron. So when you activate this inhibitory interneuron, it's going to inhibit the pain signals coming in. And this can happen with both the pain fibers and the light touch fibers as well. And this explains beautifully the instinctive behavior that we have when we bang our knee against the table. The first thing we do is rub it, right?
Right.
And that will actually diminish the pain. And so what's happening when you bang your knee against the table, all the A delta and C fibers are sending that pain signal into the spinothalamic tract.
Right.
But when we rub it, we're activating the large diameter fibers, and it's inhibiting this inhibitory interneuron, or it's exciting this
Right.
inhibitory interneuron, which is then diminishing the pain signal here. So it's a beautiful system, and it's important to understand that, to understand what we're going to be talking about with the descending inhibitory pathways.
Well, folks, if you are over 40 and you are not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to the health of so many bodily functions, not the least of which is cardioprotection. If you have any question on nitric oxide, I suggest that you register with Approved Medical Solutions and begin receiving their educational emails. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, Approved Medical Solutions created the only nitric oxide replenishment formula without oxalates. Approved Medical Solutions does not use beet, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you'll receive a 10% medical discount savings. You can register to receive educational emails without any purchase. For licensed practitioners, you too can go to approvedmedicalsolutions.com and get registered today. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see every one of them be deficient. When they see this result, they will want you to start them up immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.